think it was something that is worse.
Okay, well,
But, you know,
that's you.
yeah.
That's the circles you run in, mister.
Yeah. Right? The one guy. Actually, he's probably listening to it. Hey, what's up?
Oh, man.
You could get sick. Ick. Real quick.
Welcome back to Poutine Politics, Canadian issues served with cheese curds. My name's Adam.
My name is Mike.
And today, Mike's going to talk about...
I'm going to talk about the opioid crisis. Now, obviously, trying to solve the opioid crisis in one podcast episode is a little bit of a daunting task.
No, just a bit.
But there's so many facets, so many layers to it that trying to solve it in one episode will not do it justice.
Yeah.
Which is why I'll say that I could expand on it, different topics much further, but I am going to highlight some things that either we can immediately do or things to help out in different ways. And I'm just looking at three big things: prevention, harm reduction, and treatment.
Okay.
So prevention, I look at it first thing first, education. Because when I say opioids, I know for a fact that before I researched this, I only kind of knew what it was.
Yeah. Yeah, I'm not far behind you there. I mean, I know that part of the problem is that certain, not pain relievers, but like certain pain medication has opioids in it, right?
Yeah, most of your pain medications. So like morphine is an opioid, heroin, opioid, oxycodone, opioid, fentanyl, carfentanil. All of those are opioids. There's different classes of them based on what they are, because obviously morphine is something they use in the hospital.
Yeah.
Heroin is something that's illegal, but they generally speaking have kind of the similar effect. There's also different treatments that are opioid based, like methadone, methadose,
Naloxone.
naloxone.
Oh, that's not a really...
naloxone.
That's not a treatment. No.
Naloxone is the overdose bringer back, which I'll touch on later.
Yeah.
And then buprenorphine. Don't know what it is, but like I said, I'm not educated on this from that standpoint, because, and I want to make sure I'm clear on this. At a very young age, I took a look at drugs in general, and I realized that they are poison, and was like, why am I putting poison in my body again? And quickly figured out that that's not what I want to do. So when I say like, you know, I don't smoke, I don't drink, I've never done any opioids, you know, all this kind of stuff, cannabis, no, all this stuff, it's all in the same family, I'll say, and I just haven't, and that's just the way I am. And I know because one of the reasons why I'm also addictive. I have addictive personality too.
Yeah.
So
I very quickly looked up buprenorphine.
yeah,
I'm going to say that that's how you pronounce it.
Sure.
But it's interesting because looking at the description of it, it is an opioid used to treat opioid addiction.
yes. Most of these have an opioid derivative of it.
Right. It's interesting though that you use an opioid in order to, you know, for lack of a better term, fight an opioid, right?
Yeah. So a lot of the ones that are treatment based they give you, they deal with the side effects from using something like heroin, but they don't give you the rush from heroin.
Gotcha. Okay.
Okay. So there's not a emotional connection to it.
I guess it's
not a psychological connection to it.
It's the chemical composition, the way that it's created or processed, right?
Yeah.
Okay. Probably something like that.
Yeah, some doctor knows, but I don't know. And oftentimes, a lot of people use opioids just to deal with things. It's an escape mechanism for a lot of people, but it's the same reason why, you know, we care so much about celebrities and like movies and things like that, because they're an escape for us.
Right.
So it's kind of that idea. Now,
I would much rather be addicted to movies.
True. But the problem is that a lot of, and for medical reasons, they prescribe opioids to treat symptoms rather than curing the cause, which is part of the problem.
Yes.
And it basically is like your car is making a rattling sound. So what do? You turn up the radio. And this brings me to my next point about medical treatment, which is under education and prevention, is that doctors, they have a rough go of it, right? Like, understand, they've got you in front of them for, let's say, 15 to 30 minutes.
Oh, it's generally 15 minutes. That's like a cutoff point. Yeah. I guess it depends on the circumstances.
Depends on the circumstances, but they don't have a lot of time. They have to quickly assess you.
Yeah.
And oftentimes the easiest thing to do, or it was, because there's a big push not to anymore, but it was, I'm complaining about back pain. Well, there's opioids out there. I'm going to give you something for it. Now, opioids weren't originally designed to do that. They were designed to help cancer patients who were dealing with severe pain, whereas back pain may not be as much.
Probably not quite the same.
No. And here's the thing. The doctor's going to do what they think is best, and I don't fault the doctors. As a society, we should take the time to realize what drugs we are taking and ask questions. That's why the doctor's there. Ask as many questions as you can. You should educate yourself and decide for yourself if that's the right drug. Because oftentimes they can give you a multitude. They can give you 5 different types of drugs, right? Like maybe you don't need opioids. Maybe you need Tylenol 3s.
Right. Well, and
for
that's
your pain.
That's why there's that tends to be various reasons why there's different drugs you can take for the same usage, because there could be one that's made that would work for a standard person, and then let's say somebody has like liver disease. They can't take a certain drug because of what it contains and how it would affect their liver in the process of trying to treat the other problem that they have.
Right. Exactly. Yeah. And they need to start looking at like for back problems, so some doctors will describe a steroid and an opioid. Well, the steroid helps the cause. The opioid helps the symptoms.
Yeah.
So you shouldn't treat the symptoms as much. And the problem is once you're on the track of opioids, it's a dangerous track, right?
Yeah, because they're highly addictive. Whatever makes you feel good. If it makes you feel good, you're more likely to take it, right?
Right.
Problem then is you do run into a situation where over time you potentially need more of it to feel the same way.
That's where it gets problem, right? And this is the thing where I'm going to go straight into harm reduction. Is that the thing about opioids is that it goes from so now you're taking prescription drugs, and now you're trying to find ways to get the prescription drugs, and then your body naturally develops a tolerance to it.
Yep.
Well, then you're taking something else to try and numb that pain. And then you take something else to try and numb that pain. And then it just escalates, right? So then you go from opioids to Oxycontin or hydrocodone or something like that. And then you're trying to get medical morphine. Morphine doesn't do it to you. Nelson, you're like, I need something. And the people that you've been buying from, they're no longer legal people. Now you're in the legal drugs, prescription, but still legal. Now they're like, what's the next step? Well, the next step is heroin.
Yeah.
What's after heroin? Fentanyl.
Fentanyl.
What's after fentanyl? Carfentanil. And the thing about it is that there's such a stigma attached to drug users. And it's unfortunate because I've never been a person, even though I've never done drugs, I've never been a person like, oh, you're disgusting, you're junky, you're so gross. I get it.
Yeah.
You're so addicted to it, either like some people are so addicted to it psychologically, right? Marijuana comes to the example for that, right? The carefree drug where you don't care about anything. Well, part of the problem is that you don't care about anything, so things just get left, right?
Right.
Like your job, I don't care about going to that day. Whatever.
Yeah.
Right? So it's a sociological aspect of it. But with heroin, especially with the opioids, okay? Dope sickness is so hard on people. You wake up, and I want you to paint a picture. You wake up, okay? And if you haven't had your opioid of choice for a day, you'll wake up, you'll start puking, you'll start with diarrhea, you'll start with leg shaking, you'll start with sweats, you'll start with hot and cold flashes.
Yeah.
And that if you're hard enough and you're at this point that this sickness is not going to get better, it's going to get worse. You have the possibility, if you're that high level of dosage, that you can die from this. You can die from the withdrawal.
Yeah. That's why when you're at that level, you can't get off cold turkey.
No.
You need to have.
You need help.
Yes.
Desperately need help. And all you think about, your entire focus is not on getting help. It's getting high again.
Yeah.
And not
you'll
really
feel better.
Yeah, because it's a state of
because you know that's how you know in your head that's how you'll feel better.
And a lot of people say that people on drugs are in denial. They're not in denial that they're on drugs. They're in denial that their addiction's that bad. So they think that they can manage. They think, just one more day, I'll be fine. And the thing is that when you're on drugs like that, because it's so overwhelming. Like I'm not saying those people. I would be in the same boat. Like, I'm not saying like, oh, well, those people would do it. No, I would be in the same boat. I would lie, cheat, steal, go in the back corner and hook, whatever I had to do. And once they get to this point, and I'm talking with these people at this point, and this is where the overdose crisis comes in.
Mm-hmm.
When you're at that point, you know that you're taking your life into risk every time. You're playing Russian roulette.
Yeah.
Because you have no idea what's in that. Because there's no safe supply.
Well, that's the biggest problem with the fentanyl stuff right now, right?
Like fentanyl's horse tranquilizer, car fentanyl's elephant tranquilizer. Basically.
Really?
Yeah.
Oh, I didn't even know that.
And the reason why people seek that out is because, well, now I can last 36 hours without being dope sick.
Right.
It's not 14 hours. Now it's 36 hours. Yeah. Maybe I can function for maybe if I take this one hit, it'll be enough for me to get off it possibly.
Right.
Right. And it's just sad. Like, it's so sad. You know, like these people, and that's the reason why they're dying is because you don't know what other things they mix into it. So let's say, you know, you're buying it from the same guy. Well, this week it had 5 milligrams. Well, I have no idea. Like, anybody who's listening that knows the ratios, please don't come at me and say that the milligrams are off. I'm aware. I have no clue. But, you know, let's say if you have 5 milligrams of fentanyl this week and next week it's 20, well, you take the same shot, you're dead.
Yeah.
And you've overdosed. And the thing is, the worst problem about overdosing is that, and this is the tragic part about overdosing, overdoses are preventable. So it's not like you do die, but you can come back.
Yes.
That's where
naloxone comes in.
That's where naloxone comes in. That's where safe injection sites come in.
Yeah.
And that's a big push. And Alberta, Ontario said no more safe injection sites.
BC was, I think, thinking about it too. I think when the Liberals were in power in BC, they were contemplating getting rid of the safe injection sites as well.
Yeah, but they're gonna have they're gonna have a hard time against BC because that's where the first safe injection site at Vandu is.
Yeah.
They have a severe, they have a drug unit up there.
Yep.
And they're going to get a lot of pushback. I can't see that.
And I can't see it either because you have to think, especially with mentioning the fact that a lot of this stuff is imported from China. But imported. Obviously, it's imported illegally.
Yeah.
I mean, BC is still probably the hardest hit by it.
Oh yeah, for sure. And they're the ones that are having the most overdose. And one thing that happened in BC, skipping ahead a bit, they switched from methadone to methadose.
And it's not. Is it not as effective, I guess, or?
Well, it's a different drug.
Okay.
Beginning of the day, right?
Yeah.
So it might work for you, but it doesn't work for me.
Right. Okay.
But it's been working for me for the last 15 years.
Yeah, the methadone's been working for 15 years, and now
for me,
yeah.
it might start working for you now, but it's been working for me for 15 years.
Yeah.
And now all of a sudden I have to chip, and chipping is where you go out and seek heroin to supplement.
Right. Okay.
In order to get by, because you're having shakes.
Right.
Because you're now, and you know what dope sickness feels like. And you won't go back there. So you do everything again. And now you're downward spiral. And people saying it should be free. I'm like, it costs $5 or $7. Listen, if you've been doing heroin, you can find $5 or $7 a day. I'm sorry.
How much heroin costs. Or
right,
as far as, not that I know what it costs, but I have an idea.
Yeah, it's
not cheap.
Some people's habits are $500 a day, right? Some people's habits are only $30, but whatever, right? The idea that a safe injection site is a bad thing in your community, if your community needs a safe injection site, you should be promoting it.
Yeah.
Because if they don't do it at the safe injection site, they're doing it in the alleyway.
Yeah, exactly. Yep. At least, and which is going to cause a whole other host of issues.
Right?
Or does cause a whole other host of issues.
Because then you're getting drug users to go everywhere.
Mm-hmm.
At a safe injection site, they can go there, they can be safe. And keep in mind, as much as they are participating in illegal things, which they are, I'm not denying you that, but they can get clean needles.
Mm-hmm.
They can get supervised. No one has died from overdose at a safe injection site in the world. And especially now with fentanyl and carfentanil, more and more drug users that are in a drug user community carry Narcan with them. That's the brand name.
Right.
Naloxone is the actual thing. But they carry Narcan with them. They know how to use it.
Mm-hmm.
Right? So, when they see somebody overdosing, they can get to them quick. And they know what to look for too, right?
Yeah.
So it may not be even the legal sites that open up. They may not be. There might not be a nurse there necessarily that can supervise it, but they know what to look for. You're a drug user, you know what an overdose looks like. If you've been using long enough, you know what an overdose looks like. I wouldn't know. I have
no idea.
But, you know, they know what the symptoms are, right? And which is why it's so frustrating when I see like an opioid crisis and they're like, well, no, it's more safe injection sites. I'm like, what are you trying to avoid?
Well, really. Oh, okay. So you don't. It's like so you don't want the safe injection site. So you want these people, like you said, wherever.
Right? Like these people that are suffering from dope sickness, they're going to get high.
Yeah.
So what are you telling them? You're basically setting those people a death sentence.
Yeah.
Like you're saying, here's your Russian roulette gun, have fun.
Yeah. I want to just to make a comment quickly. Because I thought it was the BC Liberals that almost tried to shut Insight down, and apparently it was it was federal Conservatives, because it was a federal special exemption that Insight had to exist. Oh. And I guess the Conservatives were going to let it lapse, or we're going to let the exemption lapse.
Yeah.
Continuing on.
Yeah. So, and the other thing too is that a lot of people talk about the different laws. Okay, I am not a proponent of legalizing heroin. I'll say that right off the bat. I am a proponent of decriminalization, which Jane Philpott, the former health minister, has promoted as well. Yeah. Recently, like in the last, at the beginning of January, she did.
Yep.
And the reason why you want to decriminalize this is because there's no point, if you decriminalize it, right? Those people going to a safe injection site no longer have to worry about being hassled, because you don't want to go, like, let's say if the police have a presence outside of the safe injection site, I'm not going to go. If I have illegal drugs on me, I'm not going to go somewhere where I can get arrested, because getting arrested is the worst. Because when you have those withdrawals, like, it's so bad for these people. And like, I've heard of heroin users when they go through their detox, they're so poor, like their body's so messed up that they get touched on the leg and they have an orgasm, and a painful one.
Yeah.
Like, that's insane to me. Like, I can't imagine that. So they don't want to get busted by the cops because they can't get their supply anymore. Like, They can't get whatever they need. So the police need to not be there. You need to not, like, one of the best ways to help with an overdose crisis is not to arrest the people that are just trying to get by. And like, that's the thing. These people are just trying to get by. That's why I said prevention is important, because you don't want these people hooked in the first place, and which is another topic where, you know, I can address why you need to talk to your kids and everything like that, and how you can recognize signs, and how you don't want to enable and try and help, all that kind of stuff. That's another topic for another day that I plan on covering. But once you're at the point where you have dope sickness, you're not talking the same ballgame. Like, these people just can't go cold turkey. So,
and that's what would happen if they go to, like, if they get arrested. You know, because the question, looking at the justice side of things, okay, so they get arrested, they get taken in, okay, well, are they going to be, you know, released on remand? Is there going to be bail? Is someone going to be able to pay the bail? You know, like there's so many things that could affect it. And okay, so let's say they get released on remand. Okay, well, they're just going to go back and use more. Right. And at the same, and now you've put them in a position where they're more likely to be worried about potentially getting arrested again, which probably also means that either, well, if I tried to go to the safe injection site and I got arrested, why am I going to go there? I'll just use somewhere that I feel is private enough that no one's going to come along and perhaps increase usage.
Well, it's not increase usage. It's increase dosage strength.
Yeah.
So
that's what I mean. Yeah.
You want to get your hit, and you want to get fast because you don't want to be caught.
Right.
So you want to make sure your hit is strong as possible.
Yeah. But
that's not a good thing.
No.
You want something that, for somebody addicted to opioid, you want it to be released as long as possible. I'm a very big proponent of decriminalizing for personal use. Huge. Those people that are using often need rehabilitation of some kind, and they don't know where to get it. They need to offer as many different types as possible. I shouldn't say as many different types, but they need to offer more than like the 12-step program.
Yeah.
What has a success? Do you know what the success rate of 12 steps are?
It's less than 10%.
Yeah, it's like 5.
Yeah.
5 to 8.
Yeah.
Like,
is that specific to like Narcotics Anonymous, or is that with like Alcoholics Anonymous too?
It's both. Like 5 to 8 is for any 12-step program.
Yeah.
From what I've read.
Okay.
And I don't imagine it'd be different I can't imagine the number spiking to like 20.
Right.
But there are some programs out there that are averaging 75% success rates. Why are these not the ones we promote? And the ones that usually do is because they take a more holistic approach. Like, they deal with the causes, not the symptoms. Right.
Yeah.
Sometimes it's social economical, like you know, you're around drug users, or it's economical because we're in a bad background, things like that, which makes those ones a little bit more difficult. But if you've had back pain and the reason why you got addicted was opioids, well, let's deal with the back pain.
Yeah. Yeah, because if you can get rid of the back pain, then they won't have to take the drugs anymore.
They won't start again. You know, there are some very good programs out there, and these rehabilitation clinics that we have aren't all like that. So I've heard of wait times. I'm sorry, wait times?
Well, it sounds like our medical system in general, right?
But we have wait times for rehab?
Oh, yeah, I know.
Like that's
we shouldn't, but unfortunately, it doesn't surprise me.
Or, you know, if they do want to go the medical route, like there's a lot of people that rehab didn't work. So they need methadone, whatever it is. But there's so many different types of rehab. So like some people are methadone, Metal D, Suboxone. There's even a fentanyl patch now.
Mm-hmm. A fentanyl patch,
which essentially releases a lot lower dosage over time, because some people, the problem is that before fentanyl became huge, people were still using it.
Right.
Okay, so like it wasn't as big of a problem because people were using fentanyl in controlled ways. So it was the individual user that was using it, not the drug supply.
Yeah.
Or like the big dealers. And because they did it that way, it was safe.
Right.
As weird as it sounds.
Well,
because they knew how much they were putting in.
Yeah.
As a result, they got addicted to fentanyl. Well, fentanyl's way stronger than heroin, right? Because you're just upping basically you're gone from a person to a horse to a cow or to an elephant. It's basically the difference is, right? Tranquilizers. So they need something different. And the fentanyl patch is like a membrane that goes over top of you, and you put a patch on and slowly releases it, things like that.
Kind of like the way the nicotine patch is.
Yeah.
Similar.
Same idea.
Yeah.
Right? And it's a trial program right now in BC that they have for, you need to open these up for these poor people.
Mm-hmm.
Because the overdose crisis isn't going to stop until you give people as many options as possible, right? Because a heroin addict, they're only going to reach out if they hit rock bottom or they feel like they want to help out, which is why they need more incentives to get these people in, right? Like you go to a safe injection site, you should be greeted at the door saying, hey, help's out there. These are your options.
Yeah.
Here's how you get methadone.
Mm-hmm.
I can explain it to you. Here's how you get methadose. I can explain it to you. Here's how you go to this rehab clinic. This one works because I went through it. Right. And oftentimes most of these safe injection sites are run by former drug user, which is another thing that you don't realize, like I didn't realize, that they have people that are specifically very good at administering drugs, at giving people their needles. Because the problem is that you'll get somebody who's addicted to heroin, but they can't inject themselves.
Right.
Because they don't know how.
Right. Yep.
So they need somebody else.
Because they never have, I guess, right?
Well, it's hard to do. It's not easy.
Yeah.
So for whatever reason they can't, or they don't know how, or whatever the case may be, so they'll go to somebody that can do it. Well, these safe injection sites often have somebody there that can do it.
Right.
And oftentimes what happens is that if you've done it for so long and you've been doing it incorrectly, your veins collapse.
Right, yeah.
But you need to have a really good person. So that's the kind of thing that's what's so important, rather than getting somebody. And to get that person, you either pay for that person on the street or you have to do something else for that person on the street. The only way to tackle this opioid crisis is that you have to understand that it's not one thing. You can't say this magical pill will help it.
Yeah.
You have to take a multifaceted approach. You have to go, okay, well, we're going to deal with the overdose crisis. Okay, how are we going to deal with the overdose crisis? Let's give them safe injection sites, make sure they all have Narcans, make sure that they have different ways. So if you take methadone every day, when you go to the pharmacy also hands you a pamphlet saying, hey, this is how you can get help.
Yeah.
Every single time, because it takes one time for them to go to rehab. And now they're off methadose. And the thing about it is it's more cost effective to send them through rehab than it is to leave them on the streets.
Well, and to keep giving them the methadone.
Yeah, the methadone, methadose, Metal
exactly.
D, whatever the case may be. Oh, and methadose is cheaper than methadone, which is the other reason why they switched it over.
Well, of course.
Of course, right. It's all about savings.
Gotta save money.
Gotta save money. It's only costing people's lives.
Yes. What's next? Or is that it?
That's it.
That's it.
Because like I said, I could talk about which each drug, why opioids are illegal, because they shouldn't be. Why
Wait, should be or shouldn't be?
They should never. If you're going to argue that cigarettes and alcohol are illegal,
Okay.
why would you argue against opioids as they were?
Oh, okay. You're saying that. Okay.
As they were
get
at the turn of the 19th century,
Right.
or the start of the 20th century, I should say.
20th century. Yeah.
Yeah. As they were, they should have
Mm-hmm.
been illegal. And the only reason that they're so bad now is because they've had to increase. It's just like when alcohol was banned, they went from having, like controlled substances to moonshine, which you didn't know what you're getting.
Yeah.
And people can get drunk and die on moonshine because you don't know what's in it.
Right.
Same way. It's no different.
Yeah. Fair enough.
Right.
So you get that?
Yeah.
No opioids
No opioids.
and no moonshine.
No moonshine.
Okay. Well, I mean, I think that's a start.
Yes, it's a start.
I guess some, like you said, some potential future topics.
Yeah. Oh, yeah.
Okay. All right. Well, so I guess this has been a brief introduction to opioids and the opioid crisis. We'll bring you more of this as
Yeah.
time goes on.
Yeah, more PSAs because I love them apparently.
Well, I mean, I think this is one of those topics that's important because even
it's
here
relevant.
we see it's relevant where we live. It's relevant in plenty of areas close to where we live.
Yeah.
Right? Like, I mean, it's relevant in Canada. It's relevant in the United States. It's relevant in many places.
Yeah.
Right? I mean, this is, yeah. So I think it is a good thing to touch on. And like you said, I mean, since we try and keep these episodes to like 30 minutes, we're not going to be able to talk about all of it all in one episode. So I'm sure we'll bring you more topics on this as time goes on. Anyways, my name's Adam.
My name's Mike.